Hello, I'm Shashank Saxena. I'm a clinical assistant professor of anesthesiology at the University of Pittsburgh School of Medicine. We're going to talk about gastrointestinal hepatic system, hepatic function. I have nothing to disclose. We're going to start talking about the dual blood supply of the liver. Liver has most complicated of the circulation of all the organs. It has dual afferent supply from the portal vein and the hepatic artery. About 80% of the blood entering the liver is partially deoxygenated venous blood supplied by the portal vein. The rest of the 25% or 20% is well-oxygenated blood supplied by the hepatic artery. Here is a schematic depiction of the blood flow to the liver. Total hepatic blood flow ranges about 800 to 1200 milliliters per minute. Liver receives about 25% of the cardiac output. Hepatic blood volume accounts for about 10% of the total blood volume. 50% of the oxygen requirements of the liver are provided by the portal venous blood, and the other half derives from the hepatic artery. If the oxygen demand is increased, the liver simply extracts more oxygen from the blood in order to maintain oxygen uptake. The liver blood flow is regulated, and we're going to talk about some major mechanisms of blood flow regulation. The most important one that I want to talk about today is hepatic arterial buffer response. It represents the ability of the hepatic artery to produce compensatory flow changes in response to changes in the portal venous blood flow. So if the portal venous blood flow is reduced, the hepatic artery dilates and thereby increases the blood flow. If the hepatic artery constricts when the portal flow is increased. This is mediated mainly by adenosine produced from ATP released from portal venous vasculature as a response to hypoxia associated with portal flow reduction. Response is limited, whereby a 50% reduction in the portal venous blood results in twofold increase in the hepatic arterial flow. Metabolic control: decrease in oxygen tension of the pH or the pH of the portal venous blood typically leads to increases in the hepatic arterial flow. Pressure flow autoregulation: when there is hypertension, there is increase in transmural pressure causing stretching of the arterial smooth muscle. Increase in myogenic prevents the increase in organ blood flow. When there is hypotension, it lowers the transmural pressure and myogenic tone, that is vasodilation, which increases in the organ perfusion. Other factors are alpha-1 adrenergic receptor stimulation, which increases the vascular tone of the hepatic venules, leading to constriction and a reduction in both blood flow and the blood volume in the sinusoids. Hepatic arterial tone increases with stimulation of alpha-1 and D1 or dopaminergic 1 receptors, and decreases with the activation of beta-2 adrenergic receptors. Other factors in humoral regulation is activation of the sympathetic nervous system, which causes vasoconstriction of both hepatic and artery and the portal vein. Glucagon causes hepatic arterial dilatation. Angiotensin II causes constriction of both hepatic artery and the portal vein. Vasopressin decreases the hepatic blood flow by constricting the splanchnic blood vessels. We're going to next switch over to the metabolic functions of the liver. Liver plays an important role in metabolism. Let's start with carbohydrate metabolism. In the postprandial or the post-fed state, the main function of the liver is glycogenesis. In the starving state, the liver will metabolize the glycogen and cause glycogenolysis and gluconeogenesis, where it produces more glucose. Clinical relevance is hypoglycemia is a late manifestation of advanced liver disease and implies impaired glycogen storage, glycogenolysis, or gluconeogenesis. Hypoglycemia may also be seen in patients with large hepatocellular carcinomas secondary to increased glucose uptake by the tumor. The role of liver in lipid metabolism is mainly fatty acid synthesis, triglyceride synthesis, and cholesterol and bile acid synthesis. Protein and amino acid metabolism. Liver is the main site of protein and amino acid metabolism. The urea cycle converts ammonia and most other nitrogenous excretory products into urea, which is excreted by the kidney. Patients with significant liver dysfunction may not have the capacity to eliminate nitrogen, and thereby their serum ammonia levels rise and they develop hepatic encephalopathy. This slide depicts the important metabolic pathway in the hepatocytes. We're going to go over to the synthetic function of the liver. Here are the most important synthetic functions of the liver. The liver produces albumin, about 10 grams per day. It also produces acute phase proteins. It also produces important vitamin K dependent coagulation protein. These are factor 2, 7, 9, 10, protein C, protein S, protein Z, as well as factor 5, 13, fibrinogen, antithrombin, and plasminogen. alpha globulins and beta globulins. Important clinical significance is as follows. Elevated PT-INR are indicators of severe hepatic dysfunction. However, in patients with obstructive jaundice, a prolonged PT may be seen, which may be a manifestation of vitamin K deficiency rather than impaired hepatic function. And this slide depicts the intrinsic and the extrinsic coagulation pathways involved in coagulation. We're going to switch over to the excretory function of the liver. Liver produces bile acids from cholesterol, and bile acids emulsify ingested lipids. Drug metabolism. Systemically administered drugs arrive at the hepatic sinusoids by the hepatic artery, whereas most orally administered drugs are absorbed in the small intestine and arrive at the liver via the portal vein. Drugs are cleared by the liver from the blood via the hepatic artery and the portal vein. Hepatic biotransformation refers to metabolism of drugs by hepatocytes with the goal of changing them into inactive water-soluble substances that can be excreted into the bile or urine for elimination from the body. It involves the following reactions: the phase 1 and the phase 2 reaction. Phase 1 reaction involves cytochrome P450. It involves oxidation, reduction, and dealkylation. It modifies the drugs for conjugation with polar substances such as sulfate, glucuronic acid, glutathione, much more susceptible to inhibition by advanced age or hepatic diseases. Phase 2 reactions are catalyzed by transferase enzymes. Water solubility of the product is enhanced, usually less toxic and less biologically active than those of the parent compound. Hepatic clearance can be expressed by the following equation, where QTHBF is the total hepatic blood flow, CTHBF is the drug concentration of the mixed portal venous blood and the hepatic arterial blood, and CHV is the concentration of the hepatic vein blood. This is depicted by the slide here, where drugs that are cleared by the liver from blood flow via the hepatic artery and the portal vein. Drug concentration in the hepatic vein of highly extracted drugs approaches zero, as we're going to talk about in the next slide. This clearance is dependent on the concentration in the blood from the total hepatic blood flow. So we're going to talk about highly extracted drugs now. Drug concentration in the hepatic vein of highly extracted drugs approaches zero. Clearance of highly extracted drugs is therefore proportional to the total liver blood flow, which is proportional to the cardiac output. A decrease in hepatic blood flow exaggerates the systemic effects of a drug that is normally highly cleared by the liver. Portal systemic shunting and transjugular intrahepatic portosystemic shunts, or TIPS as they are called, decrease the elimination of high extraction drugs following their oral administration, thus leading to a significant increase in the extent of absorption. The dosage of these agents should be reduced by as much as 50%. Example of such drugs with high extraction ratio are antidepressants, calcium channel blockers, morphine, levodopa, propranolol, chlorpromazine, or haloperidol. Hepatic clearance is independent of the hepatic blood flow of the poorly extracted drugs. Hepatic elimination of these drugs is determined by the plasma concentration. Poorly extracted drug blood concentration is dependent on the extraction ratio. The extraction ratio is decreased with diminished hepatocellular microsomal function like cirrhosis. In liver disease, the plasma level of drugs will continue to rise unless the dosing rate is decreased. Example of drugs with low hepatic extraction: nonsteroidals, diazepam, carbamazepine, phenytoin, and warfarin. Liver disease may have marked alteration in pharmacokinetics and pharmacodynamics. Liver dysfunction reduces the blood plasma clearance of drugs eliminated by the hepatic metabolism or biliary excretion and affects plasma protein binding, which in turn could influence the process of distribution and elimination. Hypoalbuminemia causes an increase in free plasma drug concentration. This increase is the drug effect of drugs that are extensively protein bound. For low extraction drugs, this also facilitates elimination. The volume of distribution of some drugs may be increased in patients with hypoalbuminemia and ascites. Patients with cirrhosis have been reported to be more sensitive to central adverse effects of morphine and benzodiazepines. NSAIDs can precipitate renal failure in patients with cirrhosis and ascites because of the abolishment of renal production of prostaglandins, which are main vasodilatory substances of renal arteries. The most dangerous drugs in patients with cirrhosis are those with low hepatic extraction ratio and a narrow therapeutic range. Careful clinical monitoring of patients with liver disease treated with medication is extremely essential. Sensitive liver function tests are not available to guide drug therapy in patients with liver disease.